talking about leg ulcers and varicose veins. Varicose veins, also known as varicositis, are abnormally dilated, tortuous, superficial veins caused by incompetent venous valves. Most commonly, this condition occurs in the lower extremities. To further understand, here's the video.
Our blood vessels transport about 7,000 litres of blood every day. The veins in our legs carry blood from the lower extremities against gravity back towards the heart. The two most important mechanisms in this process are the calf muscle pump and the venous valves. During walking and exercising, our calf muscles repeatedly contract and relax. When they contract, they squeeze our veins. This pressure allows blood to flow upwards, thereby opening the venous valves. When inactive, the calf muscles relax, and the blood starts to flow backwards, thus causing the valves to close tightly and preventing further blood from flowing back to the feet. When veins become insufficient, however, they dilate and prevent the valves from closing properly. This in turn causes a reflux, which is when the blood leaks downwards and stagnates in the vein. If left untreated, this can result in the appearance of venous disease. Symptoms of venous disease vary depending on severity and may include itching, swelling, cramps, pain, and legs that feel restless or heavy. Meanwhile, visible varicose veins can also develop. Untreated varicose veins can cause inflammation of the venous wall and surrounding tissue, followed by the appearance of edema. Furthermore, blood cells can leak out of the vein into the surrounding tissue. This results in hyperpigmentation of the skin. The most severe form of untreated varicose veins is an ulcer.
The contributing factors of varicose veins include heredity, gender, age, weight, pregnancy, smoking, history of DVT, and standing or sitting for prolonged periods of time. By age 50, 41% of women will suffer from varicose veins. Similarly, by the time they reach their 60s, 42% of men will suffer from venous insufficiency. The condition is most common in people whose occupations require prolonged standing, such as salesperson, hairstylists, teachers, nurses and ancillary medical personnel, and construction workers. A hereditary weakness of the vein wall may contribute to the development of varicositis, and it commonly occurs in several members of the family. Varicose veins are rare before puberty. Pregnancy may cause varicositis because of the hormonal effects related to decreased venous outflow, increased pressure by the gravid uterus, and increased blood volume. Signs and symptoms of varicose veins include bulging bluish vein, swelling, aching pain, a feeling of heaviness in the legs and feet, itching, changes in skin color, and nighttime leg cramps. Nocturnal cramps are common. When deep venous obstruction results in varicose veins, the patient may develop the signs and symptoms of chronic venous insufficiency, like edema, pain, pigmentation, and ulcerations. Susceptibility to injury and infection is increased, thus increasing risk for ulcerations. Diagnostic tests for varicose veins include the Doppler ultrasound scan, which documents the anatomic site of reflux and provides a quantitative measure of the severity of valvular reflux. These scans are typically performed in a reverse Trendelenburg position or with the patient standing. Venography is not routinely performed to evaluate for valvular reflux. However, when it is used, it involves the injecting of radiopaque contrast agent into the leg veins so that the vein anatomy can be visualized by X-ray studies during various leg movements. CT venography can be helpful, especially if the pelvic venous structures are involved. Patients should avoid activities that cause venous stasis, such as wearing socks that are too tight at the top or that leave marks on the skin, crossing the legs at the thighs, and sitting or standing for long periods. Changing position frequently, elevating the legs 3 to 6 inches higher than heart level when they are tired, and getting up to walk for several minutes of every hour promotes circulation. The patient is encouraged to walk 30 minutes each day if there are no contraindications. Walking up the stairs rather than using the elevator or escalator is helpful, and swimming is good exercise. Graduated compression stockings, especially knee-high stockings, are useful. The patient who is overweight should be encouraged to begin a weight reduction plan. Ligation and stripping is a surgery for symptomatic varicose veins, requires that the deep veins be patent and functional. The saphenous vein is ligated high in the groin, where the saphenous vein meets the femoral vein. If there are superficial varicose veins that are close to the surface, a microphlebectomy may be performed. This procedure involves removal of the superficial varicosity using anywhere from 1 to 20 small incisions. There can be extensive bruising and risk of infection with this procedure. Thermal ablation is a non-surgical approach using thermal energy. Radiofrequency ablation uses an electrical contact inside the vein. As the device is withdrawn, the vein is sealed. Laser ablation uses a laser fiber tip that seals the vein. Sclerotherapy involves injection of an irritating chemical into the vein to produce localized phlebitis and fibrosis, thereby obliterating the lumen of the vein. This treatment can be performed alone or for small varicositis, or may follow vein ablation, ligation, or stripping. Sclerotherapy is typically performed in an examination or procedure room and does not require sedation. Untreated varicose vein can lead to ulcer. Ulcer is an excavation of the skin surface that occurs when the inflamed necrotic tissue slough-offs and appears as an open, inflamed sore. The area may be draining or covered by a dark, hard crust. Ulcers often occur in the medial side of the hallux or lateral fifth toe and may be caused by a combination of ischemia and pressure. Three most common causes of leg ulcer. Venous disease caused by veins that are not functioning, which is estimated between 45% and 90%. The second leading cause is peripheral arterial disease, and the other causes that includes diabetes and rheumatoid arthritis, as well as some rare conditions. Inadequate exchange of oxygen and other nutrients in the tissue is the metabolic abnormality that underlies the development of leg ulcers. When cellular metabolism cannot maintain energy balance, cell death results. Alterations in blood vessels at the arterial, capillary, and venous levels may affect cellular processes and lead to the formation of ulcers. Because ulcers have many causes, The cause of each ulcer needs to be identified so that appropriate therapy can be prescribed. The history of the condition is important in determining venous or arterial insufficiency. The pulses of the lower extremities are carefully examined. More conclusive diagnostic aids include Doppler and duplex ultrasound studies, arteriography, and venography. Cultures of the ulcer bed may be necessary to determine whether an infecting agent is the primary cause of the ulcer. Antiseptic agents such as povidone iodine, cadexamer iodine, acetic acid, chlorhexidine, and silver wound products inhibit growth and development of most skin organisms, are broad-spectrum and generate relatively little antimicrobial resistance and can be used for short periods of time. After the circulatory status of the patient is assessed and an absolute ankle pressure of greater than 60 mm of mercury and an ankle brachial index that exceeds 0.50 are confirmed, compression therapy can be used up to 40 mm of mercury without impeding arterial perfusion. Debridement is the removal of non-viable tissue from wounds. Removing the dead tissue is important, particularly in instances of infection. A variety of topical agents can be used in conjunction with cleansing and debridement therapies to promote healing of leg ulcers. The goals of treatment are to remove the vitalized tissue and to keep the ulcer clean and moist while healing takes place. Semi-occlusive or occlusive wound dressing prevent evaporative water loss from wound and retain warmth. These factors favor healing. When determining the appropriate dressing to apply, the following should be considered: simplicity of application, frequency of required dressing changes, ability to absorb wound drainage, expense, and patient's comfort. Tissue-engineered human skin equivalent is a skin product cultured from human dermal fibroblasts and keratinocytes, used in combination with therapeutic compression. When applied, it interacts with the patient's cells within the wound to stimulate the production of growth factors. Application is not difficult. No suturing is involved and the procedure is painless. Hyperbaric oxygenation may be beneficial as an adjunct treatment. In patients with diabetes with no signs of wound healing after 30 days of standard wound treatment. HBO is accomplished by placing the patient in a chamber that increases barometric pressure while the patient is breathing 100% oxygen. Treatment regimens vary from 90 to 120 minutes once daily for 30 to 90 sessions. Wound vacuum-assisted closure therapy has been found to be effective in treating patients who develop post-operative groin wound infections, decreasing hospital lengths of stay, rates of graft infection, and likelihood of limb loss. A decrease in edema promotes the exchange of cellular nutrients and release of